Welcome, everybody. Welcome. So glad you're here. I'm so honored to be here to help facilitate this. So look who's smiling. So prostate cancer's 2 words, not a sentence. Oops. Here we go. So I'm not Aaron Lamb, your usual facilitator. I'm Albert Schaefer. I'm filling in this month. Aaron is taking a much-needed vacation. I believe he's in Hawaii. I hope he's having a great time. So I know that it's because of because of the pandemic, the group has not met for a while, and now you guys are meeting again. So I just want you to think for a moment. What happened to you during that time? What did you do to cope? What did you do to get through the all the various different changes and things that occurred? Just think about that for a moment. Take a minute, close your eyes with me. Take a slow, deep breath in. Slow exhale out. And again, another slow, deep breath in. Exhale out. Calm your mind, calm your body, relax. Thank yourself for your patience for what you went through and your patience with the people around you that were helping you. Thank yourself for coming here today. It takes courage and strength to ask for help and come get for help. And yours guys and everybody being here is really demonstrating not only strength, but also you're demonstrating your motivation to continue to thrive and to grow in spite of what the aversive environment has thrown at us. So take time to invest in your own health, invest in the health of the others around you. For caregivers, I want your caregivers, raise your hand. Okay, I have a new word for you. You're no longer caregivers. You are now care partners. What word do you like? Right, me neither. I like care partners. I like care partners because we partner. It's not just a one-way street. Okay, well, I'll go back for a minute. So you can learn from everyone here is a volunteer, and on our website we have under personal experience, you have volunteers under personal experience, and it goes way beyond what you find elsewhere to help you gauge your own personal condition. So I want to give a shout out to Lyle for the great video message. I suggest all members to watch it if you're not already. Jean, another director and longtime member of the group. Bill Manning, responsible for putting together excellent DVDs, all the past meetings and they're available on the website. John Tassi, easy to use website that helps keep us up to date. And thank you for a great job in doing all these things for people. Steve Pendergrass, fantastic newsletter. I haven't forgotten. I'm getting there. I'm getting there. Trust me. Steve Pendergrass, fantastic newsletter containing detailed write-ups and presentations from prior meetings, as well as new information and research, and much needed a joke or two. Humor is our friend. This month, some great articles, including one that hits home with me. It's evidence linking ADT for prostate cancer to aversive neurocognitive effects. That's like memory, thought processes, errors, and things like that. Anyways, that's my story, and I'm sticking to it. It's from the ADT. Bill Lewis, who's in charge of those detailed write-ups. And this month includes a transcript on Dr. Sam Demid's presentation on testosterone as a treatment for prostate cancer. All these people make sure that none of the important information from our meetings falls through. So, there's a newcomers packet. If you're a newcomer, please raise your hand. We want to make sure that you filled out one of our sheets, and when you're done filling it out, bring it back up either to Bill or up here at the lectern. There's an information kit, articles and booklets, and for each of you who will be contacted early this week to this for your own personal situation. Newsletter contains some, cutting edge research and interest. Detailed write-ups on the presentation given at each meeting. Last month included a lot of information to help you to select a Medicare plan for next year, or for this year actually. Personal experiences. I am a survivor of prostate cancer myself, but I had a lot of cancer in my family. When I was 14, my mother died of Hodgkin's lymphoma, and in my early 20s, my father died of lung cancer, followed by still my 20s, my sister died of acute myelogenous leukemia. And, to tell you the truth, I never thought I'd ever be this old with all the cancer in my family. I didn't pick it, it picked me, but it became a transformational growth experience. And in 2000, my bride came down with CML, and she had a bone marrow transplant. A caveat to that is, interesting part about bone marrow transplant is you get the allergies of your donor. And my wife used to have a lot of allergies, and particularly to animals and pets and stuff, and her donor didn't. So she no longer has all those allergies anymore. And she always wanted a cat, so we now have a cat. But since she didn't grow up with cats, she really didn't know how to really treat them really well. So I made it her job to feed the cat, because cats like the people who feed them. But the cat still seems to like me better. And for the past 23 years, I've facilitated the All Blood Cancer Family Support Group for the Leukemia and Lymphoma Society. It's a rare occasion I'm able to be here because usually I have other commitments on Saturday mornings, but this Saturday, because Bill needed a break, my colleagues stepped in and they're covering for me for today. So I'm really honored to be here. I also want to give a shout out. We need more volunteers on a number of different levels, and we could always use more facilitators, because I think it's a really good idea that Aaron be able to have a break once in a while. I may not always be available. So if you're interested, come talk to me afterwards, and we can provide you some training and some support to help you be a presenter facilitator for this group. Okay. The next one. Okay, so again, just to raise a hand, how many's here for the first time? Okay. Okay, I want you to look at the people around you. Okay. And this is your social capital. This is your support system. And after today's meeting, take some time to get to know and meet people around you. Because an interesting thing happens with groups. You don't know what you don't know. And joining a prostate cancer group really made a major difference for me when I was going through my cancer treatment, because it gave me clues as to what kind of accommodations I needed for treatment, what my options and choices were, and it really allowed me to negotiate my time with work and people around me so that I was able to do a really good job for the people I was working for, and also maintain my treatment. Those were my two priorities. And as a result, work went great, and I finished treatment, and I'm happy to say that I'm going on 4.5 years now. My PSA level is non-detectable at this point. But, you know, it's because I knew about oncology. I knew about asking about treatment options. I knew about what type of time considerations I needed, you know, and as a result, I was able to make really informed decisions. So there's no good or bad decision. It's any decision will steady you. And people have two primary ways of dealing with something like this happening. Some people want a lot of information because they feel secure that they have a lot of information. But I got to caution you, there's a lot of information on the web that's not the best information in the world. The other people are faith-based. They want to just trust in their providers and the people around them. And there's no right and wrong to this. What's right or wrong is if you have somebody who wants a lot of information, you say, trust me. That's not going to work. Or if you have somebody who wants to be faith-based and you give them all this information, it's going to overwhelm them. So we really need to be considerate of where somebody's at and what it is that, you know, that they need. So anybody have any questions about treatment at this time? So like I said, there are a lot of subject matter experts out here that can provide you with some help and information. I know, you know, different medications, ADT, Luprin, Philemon, Zytiga, I can't even, Avodart. They become real tongue twisters. Yeah. Okay. If you have a question, raise your hand. We'll pass a mic to you. All right. Side effect discussions might not be as high. It depends on your doctor's priorities. A lot of times, you know, I've had patients come to me and they were really upset when their doctor said their disease was progressing, and then scheduled them for like 3 weeks later. And they said, you know, like they're scared. They just felt that their life was threatened. But in my opinion, if an oncologist tells you, schedule your appointment for 3 weeks, it's because he's familiar with the disease, he's familiar with the progress, he's familiar with treatment. If my oncologist got real excited, I'd get upset. Yes?
Would you please go on, because these people have to
Oh, yes.
have time to deal with.
All right, who's been here for 1 to 4 years? 5 to 10 years? 11 to 15 years? Longer? All right.
21.
All right. We're going to go on. We're on Instagram. I'm not going to read the slides because I know you folks can read. But go to Instagram, follow us. On YouTube. Okay, our website, www.ipcsg.org. You can go to YouTube, Prostate Cancer Support. And again, we meet every third Saturday of the month, except in December. Organizations need money to run. This organization, as well as any other organization. And so give out of your generosity. Give because it feels good to be helpful and help others and help this organization. They're going to pass the plate. All the literatures, I believe Gene's number is available and so is Bill, and they're really good about getting back to you. That's one of the things I like about this group. Some other support. Okay, an upcoming meeting. There's going to be a prostate cancer patient summit, February 9th through 10th at the UC San Diego Market. And there's the website information. Oops. Again, we need volunteers. This is a volunteer organization. And I really have gotten a lot out of volunteering. It really feels good to give and help other people. And also, I've received a lot of help as well. So don't be afraid to speak, come out and become a volunteer with us. You need to be the CEO of your own healthcare. Okay, doctors, nurses, social workers, we're all subject matter experts. Our job is to give you the information you need so you can make the best decisions for yourself. And we are not medical professionals, and any sharing by anyone in the group may not be substitute for your medical counsel. Okay, again, we need your support. Donations are tax deductible. There are no medical or religious affiliations with this group. All goes to the website advertising. Contacting people. Our next upcoming meeting, 3 members will share their story about their journey with prostate cancer. Dennis Hinckley, Don Wang, North County Cancer Fitness, Carla Going, President. And this is your chance to get all your questions answered by men who have been there and have done that. And with that, my pleasure to introduce our guest speakers. Would you like to introduce yourself?
Oh, sure. I might need help from someone on.
Okay,
Tyler, can you help me? Hello, everyone. I know many of you. My name is A.J. Mundt. I'm the chair of radiation oncology at UC San Diego. I'm a radiation oncologist. And so in January each year, I have the honor of giving an update on radiation oncology. The radiation treatment for, sorry about that. So I'm A.J. Mundt, the chair of radiation oncology at UCSD. And I've had the wonderful honor of being with Gene and Lyle and over the years, and having the honor of kicking off each year, giving sort of a radiation update. And so I sort of try to change it each year and talk about the different things, but I also recognize that many people are new, so I do some basics as well. So over the last couple years, what I did was, instead of just me droning on, I've brought a few of my colleagues with me. And thank you so much. Let's see. Oh, good. So this year, in addition to myself, I have 3 others, I'm sorry. One is actually giving a bladder cancer support group lecture right now, and he's going to appear. So if he comes in here and
mixes up the word bladder and prostate, just realized where he's rushing from. And so there's another world, right next door to the prostate called the bladder, and the cancer, unfortunately, in the bladder as well. But he'll be here. That's Brent Rose. And the other two that are with me are Jim Urbanic and Tyler Seibert. Tyler presented last year about imaging, and he's going to give some interesting imaging updates. So what I like to do, I'm going to give a little bit about radiation, sort of the basics, and it will give us some terminology to use when the other lectures are going on. They're about 15 minutes or so long each, because I like at the very end to leave time for a roundtable. And so I'm going to just bring some chairs up here, and then we just open the floor to questions about radiation. If you want to ask about protons or regular radiation or brachytherapy, anything that you learn about during this time or have been through, I'd like to leave some time at the very end for this. So usually I was going to have Carl Rossi present. He's the lead radiation oncologist at the Proton Center. Unfortunately, he wasn't able to do it, but we have a wonderful pinch hitter here. We have Jim Urbanic, who is the director at the Proton Center for UCSD, very experienced radiation oncologist in protons, and he's our pinch hitter today, and we really appreciate that. Pinch hitting, yeah, it's a good thing. So here are different speakers, and I'll introduce them as we get closer. I do want to point out that some people have asked, when I presented, they said, well, I was treated at UCSD and I had a different doctor. It's like, these are not the only ones. Our team is actually a lot larger, and we're spread around San Diego. So if you're treated in South Bay with a UCSD doctor, the nice thing is we all work together and you have the same treatment as if you were in La Jolla, because that's always a worry some people have. Because they get together and they establish guidelines. So when you walk in the door one place, I promise you, you're not going to get a different treatment if you walk in a door in another place. That's often a scary thing with a university with a lot of different people. So let me now give a little bit about the intro to radiation oncology. There are 3 pillars in the treatment of prostate cancer. You can have surgery. Many of you have had surgery. You can have medical therapy, and that's the chemotherapy, Luprons, the injections, the drug therapies. And then we're the 3rd pillar, we're radiation. It's kind of an interesting thing. In medicine, you're either a knife, like a scalpel, or you're a drug. We're the other thing. We're an energy beam. So it's kind of we don't really fit in sometimes with a lot of people's thinking, but we're the 3rd group. And it's kind of nice because we don't cut and we don't, inject. So we're kind of an interesting other group. So these are the different kinds of things. You hear prostatectomies, robotic, prostatectomies, hormone therapies, chemotherapies. We're the last group. And we have 2 main types of radiation. From the outside, appropriately called external beam, you lay on a table and the machine comes around and radiation comes at you from the outside, but you can also have it from the inside. We could put radiation inside you, either permanently or temporarily, and that uses the word brachytherapy. It's from the Greek brachy, which just means close. So close therapy is where that comes from. We're not a new kid on the block. Surgery has been, since, Inca and Mayans, they've been treating lots of things. But we started around the turn of the last 2 centuries, ago. So about 1909 was the first patient that I saw that was treated with radiation. Radiation was discovered in 1896, so it's not that long, about a decade after it was discovered, it was first used. There are 2 important approaches to radiation. We call definitive treatment, which means no surgery, just we're alone, and we're going to go for the cure with just radiation. That's definitive radiation. But there's also another term you'll see on the internet and other oh boy, let's see. Not sure what happened. It's back, okay, good. Not a good thing. So the other form is called adjuvant therapy. And adjuvant comes from, doctors like Latin and Greek, from the verb adjuvare, which just means to help. So you're having surgery, and sometimes we need to come in after surgery. Some of you have had that. I've treated some of you after surgery with adjuvant therapy. We often use the terrible word called salvage therapy. I hate that word, but it's kind of a nasty thing. But we're saying if you go through surgery and the PSA rises, sometimes we come in and treat. That's not definitive treatment. You don't have a prostate anymore. We're coming in just to help or to clean up any cancer cells after treatment. So the two main types, most importantly, external beam. Patient lays on a treatment couch. We call it a couch. It makes it sound comfortable, but any of you who have been through this know it's a hard table because we need to keep you flat. We need to do it still. If we had a really nice couch to lay on, it wouldn't work so well, but we call it a couch. And then we use computer assistance to help focus this energy beam to treat you. There are two main types of energy beams: photons, which are just X-rays, and then change the H to an R, protons. It's confusing. Photons and protons, they sound really similar, but they're very different. A photon is an energy wave, where a proton is a particle, and they're very different. An energy wave doesn't stop. It goes in the body and starts to fade into the body, but a proton goes in and gives all its energy and then stops. So they're very different, but they just have one letter different, which is very confusing. The machines look really different. On the left is a machine for photons. You lay on a table, this machine can go around you. It's about, it fits in a room. The one on the right is the proton machine. You don't see this, but in the middle of the picture is a guy standing there. Behind the wall of where you're treated is a huge machine. But when you're getting treated with either photons or protons, it just looks like a room with a tabletop, and the machine, you can hear it in moving around in the background. But if you pull the wall away, and I think you probably show a picture or two, it's a huge machine, but you wouldn't see that when you're getting treated. When you receive radiation, an important thing is how many treatments. We talk about 5 treatments, 20 treatments, 28 treatments, all these different things. Medical doctors, again, use a word that's not a normal word. We call it fractionation. So conventionally, we give little bits over many days. Many, many years ago, not too many years ago, 10, 15 years ago, we would treat up to 44 days of treatment, give you a little bit over 44 days, weeks and weeks of treatment. In the last maybe 10 years or so, it's become very popular to shrink the number of treatments. So again, we use a weird word, hypofractionation. We're causing it to get shorter. And some patients will come to us and go, well, I don't want the shorter because I want all the dose. I don't compromise my dose by giving me fewer treatments. The thing is, the treatments aren't equal. When we do fewer of them, we're giving more per day of treatment. So you're getting a more powerful treatment. So when someone goes from 33 to 28 to 20, we're not just lopping off, the amount of radiation at the end. We're actually compressing it. That's a good and bad thing. Good, because fewer visits, right? You're not schlepping back and forth continuously, you're getting treated. But the negative is you're getting more per day, so we gotta be really careful how to do that. And when we get down to like 5, 4 treatments and you're giving it all, we have to be very careful that we're not missing and we're not over-treating the bladder and the rectum and other things. So there's goods and bads, convenience, but we have to balance that against, safety and things. The good news is, oh yeah.
Is the total dose the same?
The total dose with a number, biologically it's the same, but it won't be exactly adding up to the same number of units. Because when you give it fast, it's more of a punch. The same amount of radiation will be more powerful. So actually the units all add up to sounding like a smaller number, but they're not. They're given quickly. And so when a radiation oncologist will talk, they'll always say, when we talk to each other, we'll talk about how much and how over what time period. You got to know both things, because it could be, if you gave the same dose over 2 months, it wouldn't do anything. It's just too little per day. But if you gave it over 3 days, it'd be like, wow, that's a lot of radiation in a short period of time. We can go as short as 5 days or 4 days, and that's what this stereotactic body radiotherapy, so you'll see on the internet and other places, and some of you I know were treated this way, SBRT, and that's a very big dose of radiation over a very short period of time. Goods and bads with that. The most important thing, needs really good care, quality, safety, but it could be a really good way to go. And so certain treatments, we sometimes do that, and it can be very effective. Brachytherapy is a whole other kettle of, not worms, but kettle of something. It's just a different thing because it's inside you. So we can do it traditionally, we put radioactive seeds inside you, and I know some people had that. Sitting here. A more modern method is to stick temporary radiation in you. So with a needle that we put inside temporarily and then take out over a few minutes. And we do that a number of times. So there's the permanent and the temporary. And so that it's permanent is not that common as much anymore. The temporary is more common, and it has less side effects than the permanent. We're actually starting up down in our new center in Hillcrest, a new temporary brachytherapy program. I lost my doctor who moved away to Kansas, John Ike. Some of you I know were treated with John Ike, and he was an expert in the permanent seeds. But we're starting the temporary one soon, which I'm very excited about. So let's talk about the process. First, you do a consult, which is just a doctor visit like you do, with a cardiologist or whoever. You just meet with us, talk about things. The next step is something called a CT simulation. Again, a weird word. Simulation is just like a flight, when like a pilot uses a simulator to plan a flight and learn how to fly. We use that with you. You lay on a table, we take images, and we prepare what we're going to do. I call that a mapping session. It's just easier. We measure things, get things ready for treatment, and then you go away, and then we plan it out on the computer. So we take everything about you, we draw the prostate, we plan, and we program the computer, and then you come back and you get treatment every day. And so the treatment every day, we want to make it the same every day. And many of you who have been through this will be like, oh, it's frustrating. My bladder has to be this full, my rectum, and they take you off the table to make it, all the same, because we're trying to make it identical. Like when you take, let's say you get an infection and you take, an antibiotic, the pharmacist makes sure that each pill has the same milligrams, the same thing. They want it identical. We're trying to do the same thing, even though we're not a drug. We're trying to make each treatment identical. And that's an important thing. So we meet with you and talk with the patient. We talk about the options. You might choose between surgery and radiation, and all that kind of thing happens. Then we do this mapping. It feels like a CAT scan, going through a CAT scan, but we don't inject any contrast. You don't have the things that you need for, if we're searching for a cancer, you have to have the injections and, we call contrast. You don't need that for the planning. Then on a computer, we work out how we're going to treat, and we plan the number of beams, and our goal is to treat the prostate, maybe the seminal vesicles, maybe the lymph nodes nearby, but we want to treat a target, and then we want to not treat things like the bladder and the rectum and the small intestine. All these things we want to avoid. So that's our goal. Treat what we want to treat, minimize treatment to the nearby normal tissues. Because if we can minimize the dose to the normal tissues, we can minimize side effects. So our goal is, in a perfect world, is just the prostate, no rectum. No, we want to be able to do that, but we can't. So we do as much as we can to minimize the dose to the nearby tissues. And then the treatment, you go on a table if you're having the external radiation, and then we treat over a number of 5 days, 20 days, 28, depending on your situation. So recently there's been a nice thing that's been, and I know I can see, as some of you I know have been through this, we've been putting some gel between the rectum and the prostate, which is kind of nice because, as I said, that we use the computer to try to minimize the dose. This is a nice one. You put some gel and you push the rectum away, and then we can minimize the dose to the rectum, which is, I think, really exciting. That's called a space OR. It's kind of annoying, but the OAR, but just think of it as a way to push something away that we want to protect and give some space between what we're doing. The nice thing is that gets absorbed back over a number of months. So if you check on it like 5 months later, it's gone. So it's absorbed by the body, which is nice. Okay, so when we do definitive radiation, we could do the most commonly use external beam. That could be protons or photons. Conventionally fractionated, all the different ways. But the important thing is you're getting radiation in place of surgery, but we're doing it over a number of different ways. Or you could have brachytherapy, or you could have a combo, of these different things. And there's different situations you'll have one or another. And it's often combined with things like Lupron. So Lupron is a drug that lowers your testosterone. I don't have to tell lots of people in this room who've had Lupron, it's hard. Men like having their testosterone, not only because of sex and your libido, but also your energy, your just vigor, and a lot of good things, your muscle mass. Testosterone is a positive thing, but unfortunately the prostate cancer grows because of testosterone, so we're stuck having to starve the tumor. The good news is, unlike when a woman goes through menopause, the woman in the room, you don't get your estrogen back. Most of the time, if you've had 3 or 6 months of Lupron and other things, your testosterone will start coming back after that, which is nice, because then you start feeling more energetic and things. Another difference between men and women, unfortunately, when the estrogen's gone, the estrogen is gone. And then after surgery, it's mainly an external beam thing. We don't do brachytherapy, we don't do SBRT, we don't do all these things. It's only radiation from the outside because there's no prostate anymore to treat. We're just treating little cells that are kind of left behind. We often use imaging to help guide us for where to aim, and Dr. Seibert's going to be talking about MRI and other advanced methods to help us aim our radiation. So the imaging, this group, and Lyle and Jean, a lot of people were way ahead of a lot of people. I mean, I remember 15 years ago plus, really felt imaging is important. And a lot of doctors didn't do much imaging, maybe a bone scan, CAT scan, not much. There is a lot of imaging today. And imaging for a radiation oncologist is a map. When you go on a trip, it's kind of nice to have a map to know where to go, right? If you're not aiming, you're not wandering around. And MRI, PSMA, PET scans, all these things radiation oncologists love because it just helps us go, I want to do that, and we can circle it, we can program the computer to aim, and we can do all these things. It's not just, shooting at something that I did in the early 1990s. I would just take a CAT scan and circle the prostate, and that's, we're a little more advanced than we were in 1993, but sadly, some people don't do that. And we have imaging in the room now. This is a big deal. So you can have outside the room things like the PET scans and MRIs, but in the room, the machines, the modern machines now image you, and they can see where the bladder and the rectum, and they can adjust the right on the fly where we're aiming. So many of you who have been through treatment know you lay on the table, the machine hums for a little bit, then the table moves, and then the treatment happens. The first part where you hear the machine on and then the table moving is the imaging to focus that we want to make sure we're aiming at the right place. I have to say, much of my career was lining up to marks on the skin. And we would put some marks and we would aim, not so good. And so to make up for the not so good image, aiming, we treated a bigger area to not miss. So it was an important way to get around it. Today, we know where your prostate is, we know the bladder and rectum, and we can aim. Some people will say, well, why do we still need the worrying about how much water to drink and all these other things? Because we still like filling up the bladder, pushing the intestines away, protecting the bladder from much of the radiation. There's some good things still about making sure you're treated with a comfortably full bladder, not crazily full bladder, but just comfortably full. Okay, so this is one of my doctors who's going to be late. He's going to come running in. Usually I would have him go first because the lecture that he's going to give is sort of opening up the hood and saying, what is the radiation oncologist thinking when they're talking to you? So we're going to flip the order a little bit. So he's an associate professor in my department. Some of you were treated by Brent. He has a joint appointment in urology. He was trained at Harvard University, not a little place on the East Coast. And he's an expert and well-published in prostate cancer. He works in La Jolla and the Proton Center. And the nice thing, his lecture is going to be just sort of what am I thinking when I'm talking to you? Why do I recommend what I'm recommending? And that's it. So we're going to put that when he comes in after the other two. But we're going to start with Tyler. Tyler spoke last year. He is an imaging expert. He's an MD, PhD, and his PhD is in imaging. He is an engineer that works with MRI. And so he's well-funded, well-published, and he works in La Jolla. And his expertise is advanced imaging to help diagnose prostate cancer and to figure out how better to treat it. And so this is going to be his role. So we're going to start with imaging. Then we're going to move to protons. Usually it's Carl. But today we have our pinch hitter here, and Jim Urbanic, he is the UCSD director at the California Proton Center. He trained on the East Coast, and he oversees all our radiation services at the Proton Center. So he has expertise in both photons and protons, so you can ask him about particles and about the regular radiation. And so we're going to go first with imaging, move to protons, and then we're going to flip back to what am I thinking when I'm talking to you. And then we're going to end with the round table. Okay, so Tyler, one more.
Does this one work too? Yeah, okay, well, either way. All right. Thank you so much for the introduction and your time. It's a pleasure to be back. I've been here a few times, and we did a virtual one during the pandemic. So some of this you may have heard before if you're a long timer, but there are some updates, so pay attention. The science moves quickly, but not lightning fast. That said, getting things to patients actually is harder than making advances in the science, and you'll see what I mean by that. So radiation therapy, Dr. Mundt talked about where we started and how we used to mark on the skin and just aim big. And we've gotten a lot better, and the big change was we started using CT scans, CAT scans, and you would use that and you could see the internal anatomy of the patient in 3 dimensions, and then you can use that to target, right? So that was the big paradigm shift several decades ago. And still is the backbone of how we do our treatment planning, because CAT scans, CT scans are made from x-rays. We treat with x-rays, so we can calculate the dose that's going to go to each part of your body by using the CT scan, okay? But CT scans don't show you some things. There's better imaging now. So, this is the old way. We would just circle the prostate on the CT scan, and then we would try to treat that. There's better imaging now, MRI, and MRI allows you to actually see where the tumor is, at least the worst part of the tumor. So you can see the most aggressive part of the tumor, and that's the money shot. That is where you're most likely to have the cancer come back. If the treatment fails, it's probably going to fail there. If it fails inside the prostate. This is different from, the cancer somewhere else in your body. That's a different story. But if it's going to come back in your prostate, it's probably going to come back in that spot. So there was a trial done in the Netherlands by a great group. It was published a few years ago in 2020, early 2020. This was 4 years ago, actually. And this was a phase 3 randomized trial. That's like the most sophisticated, advanced trial that we do to decide how to treat patients. That's what changes the standard of care. So this was a change the standard of care trial, and they compared treating men with to the whole prostate. So these are a lot of words there, but this is men with intermediate or high risk prostate cancer. So these are aggressive tumors. This is not the kind that you just watch. This is the kind that can progress and spread to other parts of your body and be incurable. So we need to cure it now. They said we're either going to treat the whole prostate based on the CT, just normal, or at the same time, we'll see where the tumor is on the MRI and we'll increase the dose just to that part and treat that extra, okay? Which you couldn't do before you had the MRI. So that was the question, what can we do? And the patients didn't know, this is a randomized trial, the patients didn't even know which one they were put on, okay? It didn't take longer, it wasn't like a more obviously difficult treatment or anything, so they didn't even know which one they got. But what happened is these two curves, the red one is people who got the regular treatment, and the blue one is the people who got the new treatment. Sorry, the other way around. Thank you. Thank you. Other way around. Red is the new treatment, blue is the old treatment, and the farther you go down, that means that there was the cancer came back. All right, so here's some numbers, and you may not be familiar with those statistics, but here's what it means. The focal group, the people who got the focal boost, had 67% less local recurrence, okay? So only a third as many patients had their cancer come back in the prostate, and 44% less spread to lymph nodes or to beyond, to other parts of the body, right? Does that make sense? So they were less likely to have their cancer come back. They were less likely to have their cancer spread. and there was no increase in toxicity between the two groups. All right, so no increase in side effects. Yeah. What's that?
What is DFS?
Disease-free survival. So you're still alive and your cancer hasn't come back. Good question. All right, so better disease-free survival if you got the boost, and it didn't increase the toxicity. So, and the patients, so they didn't even know which one they got, right? But their chances of cure were much better. So fewer metastases, fewer recurrences without increased toxicity. I'm sure you're thinking, what I'm thinking when I read this, every patient should get this. If you heard there were these two options, literally no one would pick to be on the blue curve, right? But are people doing it? So we conducted a survey last year. We got 263 radiation oncologists around the world to weigh in. Here's the map. 42% of them were in the US, and we asked them if they're using it routinely. Of course, there's an advantage to being in a high-income country, but look at the high-income countries. Still, the majority were not offering this to their patients. If you look at specialists versus generalists, the generalists, did I turn it off? Still going? Nope, yeah. The generalists were unlikely to be offering it, only 30%, and that's the ones who decided to participate in this survey, which I think they're more interested in prostate cancer, right? The complete subspecialist, even then, your chance of your complete subspecialist, meaning somebody who only treats genitourinary cancers with radiation, they're still probably not offering it. And we asked them why. And there were a few reasons. Here are some of the most important ones. One is it's hard to get the MRI to line up with the CT. All right? You can kind of match them, but the prostate moves around, so you have to line up just the prostate. And that's technologically difficult, and it's cognitively difficult. Okay, so that's one problem. You need to have everything on the CT because that's how you do your planning. Another thing is that teaching your team, your staff, to do planning with that focal boost is a little bit challenging. And then the third, and probably I think the hardest to overcome, is getting high quality MRI and being able to see the tumor. Prostate MRI is not easy. So we've as Dr. Mundt mentioned, I'm an engineer by training. Quantitative imaging is my background. That's what I did my PhD in and undergrad. So we've developed in my research group, which is all engineers and physicists, we've developed a program called Precision Pro Radiation Therapy, Precision Prostate, so Precision Pro RT that we've developed and are implementing here at UC San Diego. Here's an example, fixing the MRI to CT problem. How do you get your CT scan? Here's a few different angles of looking at the prostate, which probably looks a little unfamiliar, but this is the thing. Actually, even I would have a hard time knowing exactly where the boundaries of the prostate are on the CT scan, even though this is my subspecialtist job. I look at this all the time, right? But on MRI, I can see it because the MRI is better imaging. And see this yellow structure, so I've circled the prostate in orange. In fact, I have the computer. We've taught the computer how to do that itself. So we might edit it a little bit, but it actually does a really good job now, better than most doctors can do it. I would say. I'm very confident about it, actually. And then in yellow, we have the urethra. So on CT, you're trying to spare the bladder, you're trying to spare the rectum, but a lot of the toxicity can come from the fact that your urethra is there. So you would like to increase the dose to the tumor, but not overdose that urethra. To do that, you need to see it on MRI, and you need to get the MRI into the CT space. So we're working on making that an easier solution. And once you've done that, then you can overlay it on the CT, and now you can do your treatment planning. All right, but you also need a good MRI. And I want to take a step back just because not everybody's thinking about radiation therapy anyway, or they're considering radiation or surgery. MRI is a big deal for a lot of reasons. First of all, the decision, should you get a biopsy or not? A lot of men were getting unnecessary biopsies until MRI came and showed that you can avoid it. In up to half of the men who had a high PSA, you can say you're okay. Another one is if you're going to put needles into a prostate, it would be nice if you put it into the spot where the tumor is. And the traditional way of doing biopsy is blind. The new way is MRI guided. Not every urologist is doing it this way, but they should be. That's well proven. However, they need to know where the tumor is, and it's not that easy to find, especially if your imaging is not very good. Also, if you're considering surgery, it can be very informative about how likely it is the surgeon is going to be able to spare your nerves and preserve sexual function. So you need an MRI even if you're getting surgery. And then vocal therapy, as I said, should be important for radiation, should be the standard of care. But prostate MRI is hard, so I won't spend too much time on this slide, but I want you to know that these dots are accuracy. Like, what is the chance? So if you have a high PSA, your doctor sends you for an MRI. You get an MRI. The MRI comes back positive, meaning there might be cancer here. We should do a biopsy. All right. What is the chance that that patient, when they get the biopsy, they find cancer? Because if it's really low, then what are you doing the biopsy for? If it's really high, then you sure better be recommending a biopsy, right? So this is 26, those dots are 26 different institutions, most of them major academic centers in the United States. And you can see that the accuracy on the bottom, in terms of the positive predictive value, that's PPV. So the chance that they find cancer varies from very low to very high. All right. Now the nuance here, it's not even clear. Is that do you want it to be really high? Do you want it to be really low? You worry a little bit. The ones that are really high might have been missing a lot of cancers because we're only talking about the positives here. So there's a lot of nuance. But what I want you to know is that where you get your scan makes a big difference. Who reads your scan makes a big difference because this is a subjective art of radiology. They're looking at it. They're making an interpretation. And that's a problem because not everybody gets to pick where they get their scan. And even if they could pick, they don't know who's going to be reading it that day. You probably don't even know who read your scan. And you certainly don't know which machine or what was the best one or anything, right? And you have to, if you ask your urologist, they probably don't know either, right? This is kind of high-level stuff that we know if we're in the physics of MRI and this is our job, then we know. But there aren't a lot of people who are paying attention to those details. And radiation oncologists can't aim at what we can't see. As I said, prostate MRI is hard even for the radiologist, so you're really asking a lot if you want your urologist or your radiation oncologist to be good at it. And so we need to learn how to reliably identify targets. And we're stuck. There we go. Nope. Computer. There we go. So the reality of your body is that it's complex. And so we need more advanced imaging to distinguish cancer water, like up at the top where it's intracellular restricted diffusion, from other types of water. MRI is a water-based imaging technique, okay? So you want to focus in on the cancer. And we use some advanced imaging and mathematics to get to that. We've developed a new technique for highlighting the cancer. It looks like that on the upper left. Now the cancer's standing out really nicely, right? You can see it really clearly. My kids could circle it for me, right? I don't let them do that, but they could. We're excited about this. We're using it for multiple things. We've launched a study. I pitched this idea to GE Healthcare. I said, look, the MRI is great, but it's too hard. And then that means that a lot of men aren't getting good MRI. They're not getting good images. They're not getting good interpretation. So we need to fix that. We need to make this something that works no matter where you go. And so we've launched this big study. We're doing it at 5 centers at UC San Diego, which is, of course, because we started it. I wrote the protocol for this thing. And then it's also at Harvard, Cornell, UC San Francisco, and Cambridge. We have all the radiologists involved that are involved in prostate cancer from these places. And we're asking a few questions, like one, can we stop doing IV contrast, which for a lot of reasons would make MRI more available to more patients? We're also asking if the advanced MRI makes the radiologists more accurate, and can we make prostate MRI an objective, consistent, accurate, quantitative thing? So it's like a test. Now you order an MRI, you don't have to worry too much about who read it. It still matters, but you know you got a good high quality scan, and it comes back with a score that says, yes, this patient has a 57% chance of having a high grade cancer that matters. You should do a biopsy. Or this patient has less than 5% chance of cancer. Don't put needles in them. It's just going to be a chance of infection. It's going to be uncomfortable. There's no need, right? So that's the goal. We're excited about that. That study just opened last month. And now we're making things even better for radiation oncology. Here's where we've lined up. We take prostates that have come out of the patient and we slice them like the MRI, and we line them up with the MRI, and we say, how good are we at identifying the tumors and the boundaries of the tumor? And if we use that advanced imaging, what can we do for radiation oncologists? So we did a study. We had 44 radiation oncologists participate, and we gave them the MR images, the MRI, Okay, so we gave them what they would have in real life if they were going to treat the patient and they needed to find the tumor. And we told them where the tumor was. We said, the radiologist said, there's a 1 centimeter tumor and it's in the upper right back part of the prostate. We use the doctor words for those things, and we tell them what it looks like. Now, can you please circle it so that you can treat this patient? Right, that's your job. That's your job. Half the time, we only gave them the regular MRI, conventional, what you would get anywhere you pretty much go right now. And in the other half, we gave them the new advanced MRI. And let's see how they did. The red is what they were supposed to find, all right? That's what the experts did. The 2 expert radiologists looked at it and said, that's where the tumor is. The different blue colors are what the participants, the radiation oncologists did, all right? They had a hard time. But when they got that same scan with the imaging, now they can hit it, okay? It's a very exciting for us to see how much of a difference. I thought it would work. I did not think it was going to be this impactful, honestly. Here's another example case, another patient. You know, they missed. These are the same people. That color, blue, same shade, is the same person. When they got it with the good imaging, they were able to hit the target. So we did a lot of ways of looking at accuracy. One of them was just how often did they completely miss? That's bad, right? If you don't even touch the tumor, then you know you're in trouble. How often does that happen? The dots here in red are the percentage of tries where they completely miss. So how many, in what percent of cases, patients, did they completely miss the target? We have one doctor who was almost 50% of the time completely missing. A couple that were, you know, above 30%. If you look across there, the median, the average was 14%. So 14% of the time, they don't even touch it. We're not even talking about were they getting most of it or anything. Did they even touch it? 14% of the time, not at all. The average with our advanced imaging, 0% of the time were they completely missing. So I'm not saying everybody's perfect, but we're making a dramatic improvement. The gray dots are when they have advanced imaging, and you see how they're almost all on the 0 line. All right, we have lots of metrics for measuring accuracy. Here's the one that matters. Accuracy matters. Real consequences for patients. So on the y-axis, the up and down, is your biochemical failure percentage. That means what's the chance that your PSA comes back up and you have been diagnosed again with cancer? All right, cancer came back. And you can see that it ranges from, 4% chance to 20-something% chance. Yeah? And these are different patients, and the dots are doctors' attempts, where they circled. So remember, sometimes they completely miss and then it doesn't work at all. Sometimes they kind of partially get it and then they're going to partially boost the tumor. And sometimes, you could get lucky, like you partially cover it, but then with the radiation dose, because it's not exactly perfect to 1 millimeter, there's a little bit of smearing, you do okay. But here you can see red is where they were supposed to get to. And you can look at a patient like, the second one, I don't have a pointer, but if you look at the 6% chances, if you did your best targeting for patient 2, you'd have a 6% chance that the cancer comes back. But many of the doctors were giving their patients 18-19% chance of the cancer coming back. So what does it mean for patients at UC San Diego? We're aware of this. We care. We've worked on the imaging. We've implemented this Precision Pro workflow. So now we can see the tumor. We can give safe, effective, precise therapy. We can offer our patients a lower chance of cancer recurrence and a lower chance of metastatic cancer. And with that, I would like to thank my huge team of collaborators. I definitely did not do this all myself. To rely on the expertise and support of a lot of people, and also our funders and donors and the study participants who've helped to make this happen. Thank you for your attention.
I'm just going to take a second and put my slides in the machine. Sure.
Yeah. Did I understand that the images were the same, but it was your processing that got you that? Or did you have to have a higher quality image to be able to do this?
That's a great question.
No.
We do both. We do it, so we improve the imaging quality up front by making sure that we're using high quality equipment, but also more importantly even that we've acquired the images in a way that allows us to focus in on the cancer. And that is an innovation. and it's appreciated, at least, like I said, so we've got these 5 different centers that are participating. We've started at UC San Diego a quantitative prostate imaging consortium that has another 10 institutions that are contributing data and are collecting data the way that we've taught them how to do the MRI. And then you have to have a sophisticated computer software to process it to give you the color pictures that you want.
So if you could change the standard of imaging, could you take an image from any place, put it through your image processing, and you get the quality of photo?
Yeah, we can do it anywhere first we tell them, we give them the protocols. We're doing this right now. We sent it to Harvard, Cornell, Cambridge, Oxford, we've sent them the protocol. They install it on their scanner. Now they acquire the image and they send it to me, I process it, send it back to them, and things like that.
Thank you.
Is your advanced imaging also better, giving a higher resolution for cancers that have escaped the prostate?
We don't know yet. We think so, but that's going to require, honestly, it's a harder question to answer because unlike in the prostate where sometimes it comes out and we can really examine it under a microscope, we always get needle biopsies. Once you start talking about lymph nodes or bones, it's a lot harder to get a proof with a needle, right? So it's harder, it's going to require a bigger effort, and frankly, we need funding to do it.
Questions later, please.
All right. So I'll do my piece and try and help you understand a little bit of a different aspect. Whenever I hear Tyler talk, and I've known Tyler for a long time, I learn something every single time. So hopefully I'll be able to give you the same benefit from my talk. So I always try to make sure people understand where I make my money. So I work for the University of California, San Diego. I manage the radiation practice up in Encinitas. Have some wonderful partners up there. I try and herd cats with our proton therapy program, and so I manage that program, which is a wonderful opportunity. My research interests are largely in lung cancer, and I help design and implement large-scale national clinical trials at this point in my career, and vice chair of basically the lung cancer committee for one of the big U.S. groups. And I know Dr. Mundt had already covered a good chunk of this, so I'll kind of skim through some of this. But when I see patients, this is what I'm seeing. I'm seeing 3 groups of people. So one's where radiation is the definitive treatment for them, where we're either trying to cure their tumor or we're trying to, in certain situations, provide durable local control to the spot that I'm trying to treat. Even sometimes in metastatic disease. And then I have treatment that I do after surgery where I'm trying to help basically the surgeon out to prevent recurrence, oftentimes based on statistical probabilities of the cancer coming back. And I always tell the residents there are no heroes made doing adjuvant therapy, so try and minimize your risk of causing problems. And then lastly, if somebody comes to us and has symptoms from their cancer, specifically where radiation by shrinking the tumor or trying to help the healing process can help in palliating or improving their symptoms. And so I see patients, and all of us do in the same basic pattern, before treatment, initial consultation to talk about the options. I think you'll hear me talk in this talk. There are no specifically perfect answers to any clinical scenario, and there certainly are no perfect radiation solutions in any clinical scenario. And I am not going to tell you that proton therapy is the perfect choice for every patient with prostate cancer in every scenario. What I like to tell people is you like to see a radiation oncologist who basically has all the tools at their disposal so they can make a decision based on the opportunities for treatment that they have. And I think working for the university, I have that opportunity to have all those options. We see everyone during treatment once a week. Sometimes those are quick visits. There's nothing going on. Sometimes they're a little longer. And then we see them in follow-up, and it depends on what you have for how often we see somebody. We've already gone over most of this, so I won't belabor the point. But what is a proton, right? They're all around. I'm sort of grabbing them now, right? They're in the center of every atomic nucleus, right? So you have protons, neutrons, and electrons. Protons have a mass, right? Neutrons have a mass. Electrons have a very small mass. But they're everywhere. Where do we get them in proton therapy? We get them from hydrogen atoms. Several years ago at the Proton Center, we used to get them from water. We would take water, we would break out the hydrogen and the oxygen on the first step of the process, get the hydrogen, and then once that was purified, then we would strip off the electrons and get the protons. We found, much to our chagrin, that we got impurities in the system doing that, and we had to go down for almost a week to switch out from a water source to just going to gas hydrogen. And so we run the whole Proton Center just on a few small hydrogen gas tanks. It's actually pretty fascinating because there are lots of them in a tank of hydrogen gas. And they're positively charged. And we take advantage of the positive charge because they're charged, we can steer them. We can move them around with magnets and things. So this is the famous curve of what protons do. And so the way you read this curve is based on the distance, what's the energy on the y-axis, right? So they come in to something, whatever it is, a solid, right, and they give off some energy right at the interface, and then they go a certain distance and they give off most of their energy very quickly. And that was invented by, or found by Dr. Bragg. He was an Australian, and they're finally getting protons in Australia. So we're able to take advantage of the physics and engineering of that here at California Protons, which is affiliated through the UC San Diego Cancer Network. And treat lots of types of patients, right? We were built as a 5-vault facility. We run basically 4 rooms for a variety of different reasons. It's a big center, opened on about 10 years ago at this point. We treated thousands of patients. We treat as many of the children in Southern California as we possibly can, and for pediatric cancers, we have a catchment area that extends from the Mountain West to Hawaii and kind of beyond, and that's through partnership with Rady Children's Hospital. So we're going to talk about the different types of proton treatment centers in a minute, but we are essentially on the current modern iteration of proton treatment, even though it's about 10 years old at this point. So what is the problem that we're trying to solve with proton treatment? I use all kinds of radiation. I was fellowship trained, in brachytherapy. I use x-rays all the time. I use proton treatment. So what is the problem we're solving? So I think using a non-prostate example is actually instructive, right? So this, to give you a little change of what we're looking at, is an esophagus cancer patient, and this is traditional radiation that 20 years ago when I started my career would have been what we would have done. So very simple beams, in this case coming from about 6 different directions, all aimed at the esophagus. So on the left side of the screen is a sagittal or side view of the patient, and the right side of the screen is a slice of bread view, focused in red there on where the esophagus cancer is. But you can see we spread radiation around, and that thing that's right in front of the esophagus is the heart. Right? And so we don't like to treat that because of the risk of heart disease and other problems. So then we came up with the next iteration of solutions in radiation treatment, uses x-rays as well, but now we're basically using computer horsepower and engineering horsepower to shape the beam. We're spreading it out over a broader range of directions, but we're able to focus the beam more tightly on the target. And see the push-pull of that is we're treating a bit more lung to a lower dose, less dose on the heart, and more confined to the tumor target itself. So that's layer 1. With proton treatment for a patient like this is what we're seeing. These are all the same doses. All the low dose end of this is scaled to show you the same thing. And the whole idea here is we're treating less of the patient that we're not intending to treat with radiation. That is the whole thing, right? So the imaging part Tyler showed is important. This is important in the sense of like why treat things that you're not trying to aim at if you don't need to. So the challenge in our community in medical in oncology is how do we prove this? So we do randomized trials and we have to decide on endpoints and outcomes. So for this esophagus cancer treatment, we have a single randomized phase 2 trial, 1 layer below that big phase 3 trial from MD Anderson, that showed that surgical outcomes for all complications were lower with proton treatment than regular radiation, but we have yet to prove it across large groups of patients to really give that definitive answer. And those answers are hard to get to and take a lot of time. So I always try and caution people about what we know and what we don't know. The other challenge with proton treatment is it's a moving technology, right? Here in the United States, we have basically 3 iterations of proton treatment. We have passive beam scattering like up at Loma Linda and the original Harvard Center. We have wobbling beam like Indiana, which is out of business, University of Florida and the original MD Anderson Center. And we have active beam scanning, which is done like the new MD Anderson Center, what we do here at California Protons, and basically all of the new centers that are coming online. They all start with this, and this is one of the reasons why these centers cost many millions of dollars to build. They start with a cyclotron, right? We take that pure hydrogen without any electrons on it. We put it into the cyclotron. We get it spinning up to about 2/3 the speed of light in the cyclotron, and then we extract it, right? And it goes down the proton beam line. This is actually a smaller beam line than the one here in California, where we shoot it down the beam line. The beam line has all these different magnets and focusing areas to keep the beam straight and true, and then we bend it into the individual machines. The other thing you'll find at a proton center you don't find at other radiation centers is you find a whole place where engineers are working all the time like we're in a power plant. The doctors never go back here. My background before I went into medicine is I was a marine engineer for about 7 years before going to medical school. So I get really excited about this kind of stuff, but you'll see guys basically sitting around in shorts or jeans and a t-shirt who are actually running all the power plant kind of aspects of the center back here, which is kind of fun. So we'll just run through proton beam and its kind of development over time and give you a sense of why the different technologies and why sometimes it's hard to prove some of the advances because the technology is getting better. So this would be passive beam scattering, and so this is what we do at the oldest proton centers, is you shoot a proton beam, you scatter it, the first scatter to spread it out a little bit, right, with a physical scattering device you stick in front of the beam, and then we use the second scattering device to then refine that and spread out the Bragg peak over a wider area so we can then treat the patient. It uses all physical devices in front of the beam to alter the beam. So there are going to be a lot of limitations to doing that because you can only change so many physical devices in any one beam to refine what you're going to get. So it basically you stick this device, which is like a fan that you can spin and adjust in front of the beam to then spread out the proton beam and create that effect, right? So a pretty, hardcore mechanical engineering approach to what ends up being a pretty refined, electrical engineering problem in my mind. But that's how the earliest beams did it. And they were able to basically come up with depth dose distributions look like this, which are pretty nice, but there's limits to how big an area we can treat this way, which is why up at Loma Linda they have restrictions on how large a patient area they can treat. And you have restrictions on how much you can refine the beam on the target itself, right? And then after a while, the devices end up looking pretty beat up, but that's what we use for patients. Then we go to the next layer of the technology, which is sort of that intermediate era. This is the mid to late 90s, where we start being able to adjust the beam with magnets. So now we're able to point the beam in different directions with magnets, and then we can use apertures, right, to then fully shape the beam into where we want to go. So like cutouts, basically, is how I think about this. So this is how that ends up looking, where you have basically more electronic control with magnets, and then you have devices that we're going to stick in front of the beam with compensators to change the range. So basically we take we design the lucite thing at the top to basically fit the contour of the target that we're going to try and shape for the patient. We then shove that in front of the beam, and then we use apertures to basically focus down to what we're trying to treat. So it's sort of an in-between process. But they're beautiful. I mean, it's pretty amazing, the science and the technology and what we ended up doing to make all this happen. So this is kind of what ends up happening, sort of in a cartoon way. We're able to basically design this. But if you get any inhomogeneity in front of the beam, very hard for us to adjust for that in any even close to real-time kind of way with these type of systems. And so we use a compensator to do that, but we have to design and mill that and pour it to make it all happen. So where are we at now? So all the current centers, in place since the mid-2015s have this, what we're going to look at, which essentially is using magnets to control the beam from soup to nuts, right? There's no physical thing that we put in front of the beam to focus it. And so we're able to do this. We're able to scan the beam from side to side, top to bottom, 3 different directions, and we're able to fill in the target that we want. We're able to adjust the energy and the amount of time that the beam sits at any one place in order to paint the dose that we're trying to do. And so that's where all the proton centers are now. So if you go around the country, whether it's Mayo, whether it's us, whether it's Utah or whatnot, that's what you're going to get. Okay. So this is what the business end of the machine looks like for when you're there. This is one of our physicists, and he was with us for a bunch of years. Great guy. He's in New Mexico now, retired. Rides his motorcycle all over the place. But there's the couch. It's on basically an automotive robotic arm. That's where that arm came from, the automotive industry. And you have a full set of imagers. Those are the panels that are coming out of the side here. This is how we take pictures. The X-ray sources are over here. And this is the business end of the proton machine right there. That's what we call the snout. And we try and get that very close to the patient because we like to have a low distance those protons have to shoot. If you go behind that wall of the proton machine, this is what it looks like. This is one of our radiation therapists over there at the Proton Center back in the era when it was branded as Scripps. He still works there. He's been with us for a bunch of years now. But you can see that whole thing you're looking at there, that whole thing rotates. Right, so the weight of the machine that's rotating around you weighs as much as a 737, right? And then the ceiling above, you can get a sense just above it. If we had to replace major components to this or actually jack the thing up, other than jacking it up from the bottom, we actually bring a crane in, we open the roof up, and we manipulate the equipment from the top, which is pretty cool. Kind of goes back to my shipboard life. This is the gantry wheel and the bearing that it rides on. Heavy duty equipment. You get a sense of why, you build a radiation center for, $10 million from start to finish. You build one of these centers for $200 million. And then this is what the machine looks like when it rotates around you to take a picture. And this is the fluoroscopy version of the picture. It'll then reconstruct a CT picture on the right, somebody's head we're taking a picture of. But you get the basic idea. Then once we get done imaging, then we pull those panels back, we slide the snout into position, and we go ahead and treat. So the same basic type of accuracy that we're getting on the X-ray machines across town. This is how the layout of a proton center looks. You have a cyclotron. It shoots the protons out, down the beam line, and into each of the rooms. Gantry 2, 3, 4, and the fixed beam rooms 1 and 5. And then you can get patients through that. We can treat probably a capacity of around 90 to 100 patients a day doing that. The newest proton centers are 1 or 2 beam room centers where they have the cyclotron and the gantry all integrated together as the room itself. The technology of treating patients on the output side is actually still pretty similar, but they've been able to compact the size of the center down nicely. And so long and the short of it, there are about 40 or so proton centers running in the United States at this point, more on the East Coast than the West Coast. In California, there are really 2 functional centers. The one up at Livermore Laboratory was just an eye line. It's actually over at UC Davis. In terms of treating like major cancers, and on the West Coast, there's much less access for patients. So back to prostates real quickly. So when do we do it? So this is irregardless of that fractionation question. I'll just address the SBRT question for prostate really quickly. That's that 5 treatment prostate treatment. We've been hesitant to do that. We're not against doing that with protons because we want more data that tells us for proton treatment, because the biology is a little bit different, is going to maintain that safety threshold. We don't think it's changing the cure rate if you look at the SBRT data writ large, so it's more convenient. So rather than just going to convenience, we want to make sure our safety stuff is in line. If you remember that esophagus picture, this is the story for prostate cancer. So on the left is IMRT x-rays, so it's step and shoot, 6 to 9 different directions. The next iteration was VMAT, volumetric modulated arc therapy. Those are both IMRT computer algorithm solutions to running an x-ray machine. So this is what a current 2024 VMAT prostate treatment looks like. I pulled this from one of our current patients getting treated. So very much like the picture I just showed you. Down here is kind of helpful. This is the bladder. This is the rectum and the sigmoid colon coming up. Rectum's back here in maroon. And you can see that the radiation to the rest of the body, when we're just treating the prostate vesicles, is very low, but we do spread radiation dose around in a wider area doing this treatment. But I would basically advocate to you that X-ray based treatment with a conventional accelerator, with a Seibert knife type treatment, with an MRI, LINAC, you know, it's tomato, tomato, choose your preference carefully, pick the team that you like. That's not where I'm going to argue with you about using protons routinely. Protons for this is wonderful because we do this. We treat the same target, but we basically get rid of that exposure to the rest of you. Harder for me to tell you that there's a huge delta in side effects or any, from doing that. With proton treatment, the other thing you'll notice is we like to use that space OAR, and I'll show you how we put that in a second, that rectal spacer between the prostate and the rectum. Because one thing about protons is we don't bend that curve quite as well. If you look here, see how nicely we're able to bend the high dose area of the radiation nowadays. And that's because we have those beams coming from lots of different directions. A little trickier to do that, so we love the Space OAR hydrogel for that. And there are a couple brands out there, it doesn't particularly matter. So this is how that goes in. Side view of the patient, right? So their prostate sitting right here, rectum sitting right here, and then there's a space in between the two. And then we inject that hydrogel in between and create that little bit of space to give us some room to work. It's a pretty nice way to go. That's basically the process. It's like doing the biopsy procedure all over again. We have a couple of people, both at UC San Diego and the Proton Center, who do that routinely as part of their normal job, and they've done thousands of them, and they're very good at it. And we get beautiful pictures. And so this is, the last one you saw was kind of like drooping like a little bit of a dog ear. This is a prettier one. So you can see there is a fair bit of expertise in placing these. So like anything, you want to go see somebody who does a fair bit of it. So let's cook with gas real quick before I finish up and hand the mic over to Brent. So what about when does protons, where's the big bang? Pelvic radiation, in my opinion, right? So minimal toxicity. This is, from a prospective database comparing to historical controls of outcomes. So these guys will start yelling at me about data in a second. But you'll see the pictures in a minute. Basically, the data here is suggestive that the toxicity to treating the whole pelvis is less. If you look at the pictures in a second, I think you'll see why we think that. And then this is for secondary cancers, right? So the latency time for a secondary cancer from radiation treatment is at least a decade, right? So this is a huge issue when we treat pediatric tumors. It's one of the main reasons we use protons for children with cancer. In addition to growth and development issues, secondary cancers is a huge one. For adults, it's a variable issue, but nonetheless, in terms of secondary cancer rates, they're very low in terms of actual numbers, but slightly less with proton beam treatment. And that's because of this problem. So this is in a VMAT X-ray plan when we treat the pelvis. Remember the other plan I showed you, we were just treating the prostate and seminal vesicles. When we need to treat the lymph nodes all the way up into the pelvis, then we've got to spread that dose, and we're spreading that dose over a large bit of intestine, and we're spreading that dose over the upper part of the bladder that we weren't before. Some of it's fairly low dose, patient may not notice it much, but it's there nonetheless, and it's a pretty big area, right? This is an axial slice from a little farther up. The last one was more down at the level of the prostate, and this shows you big loops of bowel, a little bit of bladder out there. This is a patient who's currently under treatment with x-rays, so this isn't some ancient picture I'm showing you. We're treating a fair amount of non-target normal tissue is the terms that we like to, the euphemism we like to use in radiation oncology. This is what proton treatment looks like. So if this was my pelvis, and somebody said, well, Dr. Manning, you don't have a ton of outcome data, I'd say, yes, sir, you are correct, but I have plenty of nice pictures that tell me I'm not delivering any radiation here or to their bladder, so I'm treating the pelvic lymph nodes. This is a beautiful way to do it. It's like a, cool drink of water, IMPT, feels good. So your doctors have choices. This is one of the choices they can make. Thank you.
What's that? It's hot. It sounds hot, right? So I'm noticing that we're walking around with a mic. So both mics work? Yeah. Okay, perfect. So that way I can choose which one I like. I like that. It's good to have choices, right? Yes. I'm sorry, can you have the slideshow? It'll show up on that side. Would you mind bringing that up? Go ahead. Hi, everybody. How is it going? I feel like I know about half the room. That sounds about right. Well, thanks so much for having us. I really love coming to this meeting, and it's so fun to get to meet and chat with everybody. I apologize I was a little bit late today because I had a bladder cancer event earlier in the morning. So my talk tends to be a little more focused on the new diagnoses, the things you need to know about the nuts and bolts of prostate cancer. So usually that talk fits a little bit better on the beginning than the end of the session, but bear with me on that, so I apologize. I know that we want to be conscientious of everybody's time. It looks like it's a little after 11:30 right now. We really like to have the session where we can sit down and do kind of a question-based format. So I'll try not to take all the time with the talking. So feel free to cut me off if I talk too long, okay?
I'm copying it over so that it doesn't fall away.
And so my topic, like I mentioned, it's a little bit more of the basics of prostate cancer, what you really need to know if you're gonna get a new diagnosis, or even as your treatment journey goes on. What are the things that you really want to make sure that you understand? And I wanted to put a little bit of a spin on it. So tell me if you like it, and if you do, I'll expand that for the next session. But I kind of like to think about, what if this was me? What if this was my prostate, my body? What would I really like to know? Because you're going to see the doctor, you're going to hear the doctor spiel, but what is the doctor thinking if it's his body? How is that going to affect things a little bit? So the goal here really, the Informed Prostate Cancer Support Group, and this is not a surprise to you, but really the goal here is to make sure that you get enough information so that you can make the decisions that are right for you. Often you go to a doctor's office and the doctor says, you need X, Y, and Z. But in prostate cancer world, that's totally different. In prostate cancer world, you get a diagnosis, it's something that you need to do something about, but you have a lot of time and you have a lot of options. So you really need to take your time, meet lots of doctors, meet other guys like you, other families like you, and figure out what's right for you. So the goal of the session is really take your time, educate yourself, make sure you're making the best decisions for you, and that might be completely different than the person next to you would make for their body, and that's okay. That's what this is about. So a new diagnosis is scary. There's a lot of new terminology and a lot of new information. I often joke with my patients that it feels like you're going to get a PhD in prostate cancer world in the next 3 to 6 months, because there's just so much to know. That's par for the course. You just got to get used to that. Let us help you, but you're going to have to help yourself a little bit too. So again, this talk is intended to give you a viewpoint of what I would do if I received the diagnosis. So first, before we can get into that, a little bit of prostate cancer anatomy. A lot of people don't know what a prostate actually does. I didn't, certainly before I went to medical school and they start to teach you about that. The prostate obviously is located in some very important territory. It's right below the bladder, right in front of the rectum, right above your penis. And so those are the sort of 3 organs that any diagnosis is going to touch on in one way or another. And again, what the prostate actually does is it creates enzymes, creates some of the fluid that come out when you ejaculate. And that helps to free up the sperm so that they can survive in the vagina and make their way up to fertilized eggs. That's what the prostate's actually doing. It is a sexual organ. And one of the things that's always happening, you may or may not know it, is that the prostate is making prostate-specific antigen. You've heard that term a million times at this point, but what is it? PSA is a protein that's being made by the normal prostate itself, not the cancer, but the prostate, or the cancer. So it has 2 components of where that's coming from. So it's really easy to test it from your blood. It's just a quick blood test. They'll tell you your PSA level is X, Y, and Z. And you use it for a couple different things. One is screening. Do I have prostate cancer? And I'll get a PSA test to know that. The next, or to help us to understand, could I have prostate cancer? The next is, if you know you have prostate cancer, how aggressive is the cancer? Is this one of those early cancers I read about in the New York Times that I wish I didn't know about and is not going to cause any problems? Or is this something I really need to be aggressive about because it is a risk to my life? After you've been diagnosed, if you choose active surveillance, PSA is going to be one of the things we use to monitor the cancer. And after you've been treated, PSA is one of the things we're going to use to say, did we get it all? Or is it possibly coming back? Or are the hormone therapies working? So it has lots of different uses. Okay. So of course, if it's a blood test, it has a range. What is a normal PSA? The problem with that is there is no normal level of PSA. There just is not. You'll often see the result and say, oh, it's less than 4, so that's good news. That doesn't really mean a whole lot. So as guys age, so imagine you're a guy, you don't have prostate cancer yet, you still have a PSA because you still have a prostate and it's making some amount of PSA. As you get older, your prostate gets a little bigger, it starts to make a little bit more PSA. So a normal range of a PSA goes up as we age. And that's a totally normal thing. That 4 number, someone just kind of made that up once upon a time, and they were very persuasive because everyone sort of took it up. But that's not really a yes or no, good or bad number. It's just a number. As the PSA goes up, if you haven't had a prostate cancer diagnosis, we do start to worry, gee, that PSA is a little bit higher than the rest of the population at about that age. Is it possible it's because they have prostate cancer? But again, because we get stuck on this 4 number, people will think, oh, it's elevated, I must have cancer. But realistically, it's not a perfect test because even if your PSA is less than 4, 15% of guys will still have a prostate cancer and just it's not making a lot of PSA, and so it's not detected that way. And then if you're over 4, most guys still don't have prostate cancer just because their PSA is a little bit elevated. So it's not a perfect test by any means, but it's what we have. You'll hear a lot of controversy these days about PSA screening, and you might have had the experience where you were getting a PSA test up until you hit a certain age and your doctor said, oh, good news, we don't need it anymore, or something like that. And often, because a lot of us have prostate cancer, work with prostate cancer, that feels a very strange conversation to have. It's complicated, it's nuanced, but often if you're getting regular PSA screening, we find a lot of cancers that didn't need to be found, really early stage cancers. Some guys will have an elevated PSA, get a biopsy, there's no cancer there, but you get an infection because of the biopsy and things like that. So there is a back and forth about the academic community about how much PSA screening we should be doing. We tend to be oncologists, we see the cancers, we see the bad ones, so we tend to be a little more pro-screening. We'd rather know about it and decide what to do. So if this is my body, I would get the PSA screening. I would do it, and if I was diagnosed with a prostate cancer, I'd collect all the information I needed and then make a decision. Just getting a prostate cancer diagnosis doesn't mean you're gonna have to have your prostate removed or radiated or all these other things. So the more information, the better, and I would get a PSA test if it was me. Problems though, of course, just as your prostate gets bigger, it's going to make more PSA. That doesn't necessarily mean you have cancer. Sometimes you can get inflammation in the prostate itself. We call that prostatitis. That can transiently elevate your PSA, and then it can fall back down. So the PSAs are going to fluctuate. They're just going to do that. Recent ejaculation, if you've had sex, if you had a digital rectal exam where someone manually manipulated your prostate, or even if you just went on a long bike ride. Those are things that can elevate your PSA. So if you don't have prostate cancer, that can really be a big scare because, oh, your PSA is elevated, and they tell you, oh, it's up. And even if you do have prostate cancer and you've been monitoring it, these things can affect those PSA levels. So make sure you know if you're about to go get your PSA test, don't go on a long bike ride for a couple days or a week before. If you've had sex, if your doctor just examined your prostate, just make sure that your doctor is aware of that and you're aware of that when you're interpreting those PSA numbers. Really, the most important part of a new diagnosis of prostate cancer is figuring out how aggressive is it. If you look at prostate cancer overall, there's probably somewhere in the neighborhood of 200,000 new diagnoses per year of prostate cancer. That's a lot of prostate cancer. But if you break it down, probably 100,000 of those are low-risk prostate cancer. Those are the types of cancers that have very little potential to spread outside of the prostate, to spread to bones and things like that. So realistically, those are the type of cancers that we almost always just want to watch. We want to monitor them, keep a close eye on them, but those are very unlikely to cause you big problems. So those are things we find with PSA screening that maybe we didn't need to find, but we do know about them and we can monitor them. On the flip side, as much as you hear about, oh, prostate cancer is slow growing, it's not going to be a big problem, prostate cancer is still the second leading cause of cancer death in men because a portion of them are very aggressive. A portion of them will have the propensity to spread if they're not treated aggressively, or potentially have already spread at the time you diagnose it. So really getting a sense of how aggressive the cancer is probably the most important thing you could do in the early stages. And we break it down. People will often ask, oh, doc, what stage am I? Because people have heard this stage 1, stage 2, stage 3, stage 4 paradigm that most other cancers use. We don't really use that paradigm very often, though. So it's harder for us to say, oh, good news, you're stage 1 or stage 2. You probably haven't heard that from your doctor very much. So we break it down actually into categories, which I would sort of simplify to localized prostate cancer, meaning it's right within your prostate, hasn't spread outside of it, or regional, which is involving the pelvic lymph nodes, or already metastatic, spread out to the bones. And those are very, very different things. The majority of guys will have localized prostate cancer, and again, about half of those will probably be low-risk prostate cancer, which is a very different sort of decision-making process. Within the localized prostate cancer, there's low risk, intermediate risk, and high risk. And just because we're doctors and we feel the need to make things more complicated, we split intermediate into favorable and unfavorable. So you're going to hear a lot of jargon. There's just a lot of jargon, and there's a lot of little potential boxes that your specific cancer risk aggressiveness can fit into. So take your time, make sure you understand where you are on this spectrum. Because if you have a metastatic diagnosis, that's important. You need to know about it. You need to be aggressive about it. But your perspective on things is very different than if you're on the other side of the risk spectrum here. Very, very different. Go ahead.
When I was going through my treatment, I would do an MRI, but nobody ever said you have anything outside of it and stuff like that. How do you determine whether it's gone outside of the prostate area?
Great question. So I'll just show you a picture while we talk about that. So the MRI is a great tool. We use it all the time. It gives us a lot of information, but it's really mostly looking at your prostate. You can also get some information about the pelvic lymph nodes, because that's kind of the first place the prostate cancer might spread once it jumps out of the prostate, but it's not looking outside of your pelvis at all. So a lot of people say, well, I got a prostate MRI, that was neat, but how do we know that it hasn't spread? How do we know? The long and short answer is that those risk groupings that we told you about are very, very strongly predictive of whether the cancer is going to spread. So if we know what your PSA is, if we know what your Gleason score is, and we got an MRI of your prostate, and your PSA was relatively low and your Gleason score was relatively low, you almost certainly haven't spread outside of the pelvis. And so in that case, we could go get a pretty PET scan like this, but we're more likely to find something that's not cancer, but for some reason lights up and scare everybody that you have a false positive result on that scan. So every case is different, right? If you have a lower Gleason score, lower PSA number, you probably don't need a fancy PET scan or something like that. But if you have a Gleason 9 or 10, your PSA is 15, 20, something like that, then you really do, because then you have to go looking for it. But if you've been kind of going through the journey and no one's told you about a PET scan, it's very likely you didn't need it, but it's very likely you need to know if you need it or not. And so this is the information to help you make that decision, to make sure that your doctor is not just overlooking that for you. Oops. All right. So, at least half of the people in this room have had this study, and it's not the most fun thing ever. So your PSA is elevated. You say, oh, you might have prostate cancer. Let's go do a biopsy to see, do I have prostate cancer? And this tends to be one of the more unpleasant things that happens to a guy in their life. So you probably, once you've had it, you never forget it. The standard way you do this is to put that ultrasound probe directly into the rectum, and then from a needle that comes off the front, you put 12 different needles into the prostate. So it's not fun, no one likes it, but you can also see what part of the prostate you're gonna sample well with those needles. And it's not over here, and they're gonna try to avoid your urethra as much as possible, because if they put the needle in your urethra, you're gonna pee blood for a couple weeks, and you're not gonna like that. So they're gonna sample the sides and the back of your prostate really well with the prostate biopsy. But again, it's a sampling. And we know that if you go from a prostate biopsy, get a prostatectomy, they look at the whole prostate under a microscope, 30% of the time you're gonna have a higher grade cancer than what they thought based on that biopsy. Just because all they're really doing is sampling the prostate and mostly getting the back of the prostate. So the Gleason score tends to be one of the most important features of how aggressive these cancers are. And the Gleason score is how we score the prostate based on what it looks like under a microscope. It's a really confusing system. It starts in 6, goes to 10, and it's funny because if you think you have a Gleason 6, then oh my gosh, what about 1, 2, 3, 4, and 5? It's already past those stages, but a Gleason 6 is actually the lowest grade cancer you can have to still call it a cancer, and a 10 would be the worst. In an effort to try to make it simpler, they've tried to convert this to a grade group designation, so it goes from 1 to 5 instead of 6 through 10. Fantastic idea, much simpler, much easier to use. But unfortunately, half your doctors will use the term grade group and half your doctors will use the term Gleason score. So now you need to know 2 different scoring systems to make it out. But here it is, long and short Gleason 6 or a grade group 1, you probably don't need to treat most of those prostate cancers. A Gleason 7 or a grade group 2 or 3, those are usually intermediate risk cancers that you need to think about. You don't always need to treat them, but you need to really make sure that you're talking to all the right doctors to make sure you're getting a good sense about that. And a Gleason 8 to 10 or a grade group 4 to 5, those are the aggressive cancers. Those are the ones with the highest probability of spreading. So those ones you really need to take seriously, okay? So as Dr. Seibert already talked about, the prostate MRI is a fantastic tool for us. And here's a nice example. And so you've seen several prostate MRIs already today, but just to point out, this is the prostate itself, and this is the rectum right here. You imagine you had that ultrasound probe in the rectum and you're putting needles into the back of the prostate. You're not seeing this tumor up here in the front. So these are the ones that you miss if you're not doing an MRI before your biopsy. So if it's me, I've been getting my PSA screening and my PSA is elevated, and the doctor says, okay, great, let's go do a biopsy. I say, no, not yet. First we get an MRI. One, because the MRI might look totally normal, and then I get to skip the biopsy. That is a normal pathway that we do now. You get an MRI, it looks totally normal, you might not need a biopsy anymore. But you might also find something in an area that's not that easy to biopsy, or they might just accidentally miss. So when my PSA is elevated, I say, okay, great, let's go get a prostate MRI, and then we'll decide what to do based on that prostate MRI. And if nothing else, I want to make sure that you're putting the needle in the dark spot of that prostate to make sure we get the worst part of the cancer. So a prostate MRI, very, very useful. Then the question comes up, has it spread? Do I need a PET scan? The long and short of it is if you have low-risk prostate cancer, you don't need a PET scan. If you have intermediate-risk prostate cancer, you probably don't need a PET scan. If you have anything else, you do need a PET scan. But it's not just a PET scan, it's a PSMA PET scan. We've been through a lot of iterations of PET scans, and in every other cancer type, they get to use one PET scan. It's an FDG PET, which is a sugar molecule with a little radioactive tracer stuck on it. But in prostate cancer, well, prostate cancer doesn't really take up a lot of sugar. So it's not going to take up the FDG PET. So we haven't been able to use the PET scan that everybody else in the world uses. So we've gone through several iterations, and now the best one that's available is what's called the prostate-specific membrane antigen, or PSMA PET scan. Very sensitive, detects cancer spread very, very well. It does have a lot of false positives, though. There often will be spots in ribs and spots that the radiologist will say, well, there's uptake and we're concerned about it, but we don't really know. So that is just something to know. When you get your PET scan, there are false positives. So be aware that not everything you see is going to be a cancer spot. Sometimes it's easy to figure out if it is or is not. Sometimes you can get an MRI or a biopsy to verify. Sometimes you're going to just get this unsettling result where they look at it and say, I don't think that's cancer, but I'm not totally sure. So something to be aware of. Should I get a genetic test? This is always a really important question, but it's really important to think of these. There are actually 2 different types of genetic testing. One is your inherited genes, what you got from your parents, the genes that you are going to give to your children. Those are the genes that are in every cell of your body. And so when someone's going to give you and they call that a germline genetic test. The reason to get one of those is to know, did I inherit a predisposition to developing prostate cancer? And if so, could I possibly have passed that along to my children? The other important genetic test is sometimes called a somatic test. It's actually what does the tumor's DNA look like? And that's very different. Tumors arise from our body because our DNA collects a series of mutations that tells the cancer to act the wrong way. Prostate cancer cell is supposed to sit there, make some fluid, do nothing else. but sometimes the blueprints of the cell, the DNA, get miswired, and it thinks it's supposed to grow and spread and do all these things, and that's from a collection of mutations. So these somatic tests actually looks at the cancer itself, which will have very different set of mutations than your inherited DNA will have. So those are very different things. The purpose of a somatic test is to say, how aggressive is this cancer, or what mutations does it have to make it sensitive to certain other treatments that you might be able to receive. And so if it's me, would I get a germline genetic test? Well, if I get my prostate cancer at 70 years old and it's a low risk, intermediate risk, I wouldn't. Prostate cancer is so common that you probably didn't inherit anything. As long as that's kind of the main cancer in your family, then it's probably not worth it. But if I get it when I'm 50 years old, or I have multiple family members who have prostate cancer, or my cancer is particularly aggressive, then I would. Then it's important to know. Would I get tumor genetic testing? And there's lots of different types of tumor genetic testing. There's Decipher tests or Polaris. There's specific Invitae Tempus, lots of different things. So if I had localized prostate cancer and I was between risk groups, I would get it. So if I'm right between low or intermediate, or right between intermediate and high, I'd say, you know, let's collect a little more information, make sure we know everything there is to know about the tumor. Conversely, if I have a Gleason 9 prostate cancer with a PSAs 30 or 40 or something like that, that's an aggressive tumor. I don't need a genetic test to verify that. It is an aggressive tumor. You don't need that extra information. You know, sometimes you have to be your own case manager, and sometimes your doctor is going to say, oh, you probably should have hormone therapy with the radiation. And you say, oh, doc, I do not want that hormone therapy. In that case, this is where genetic tests might be helpful, especially if you're on the border of needing the hormone therapy or not, because you might get that Decipher test come back and say, you actually have pretty low risk. In that case, then you could use that as one piece of information with the collection of other information to say, maybe I don't need this specific part of your treatment. But that's only, again, if you're kind of on the edges of those risk groups. And I do want to caution you that we don't have the long-term follow-up, the clinical trials that we need to say, this marker tells me yes or no, I do or do not need hormone therapy. So we're not quite there yet. But again, if you're on the edge of one of those treatment recommendations, this is one piece of information that could sway your decision one way or another, particularly if it's very important for your decision-making. Active surveillance, similarly, if you have a Gleason 7 but maybe one core, then a genetic test of the tumor could be helpful in that case. And sometimes I might just want more information, and there's nothing wrong with more information. If you just want to know everything there is to know about your prostate cancer, ask, should you get a Decipher test, a Invitae Tempus test? Sometimes that information is useful. Often it's a little more confusing than anything, particularly if it's discordant with your other pieces of information. So that's the one reason that we don't just always do it. One, it costs a bunch of money. Two, it might give you information that you don't exactly know how to integrate into your treatment. But if you just want to know everything there is to know, then a genetic test is a good way to do it. And then the important questions that I would always need to emphasize is, how fast do I need to make the decision? If it's me, I get my diagnosis, my urologist tells me I have prostate cancer, and he says, okay, we're going to go to the OR in 2 months, and we're going to get that prostate out. I say, well, hold on. How fast do I need to make a decision? Not that fast. Not that fast, okay? This is prostate cancer. Almost no matter what disease stage you're at, you have a couple months to make sure you know everything you need to know about the cancer to make sure that you're making the right decision. Are there other doctors I should see? Yes, absolutely. You should always have seen a urologist, a radiation oncologist, and usually a medical oncologist. And if you didn't like your radiation oncologist, if you came to me and said, I don't know about that, Dr. Rose, I got a funny feeling, go see another one. That's okay. That's totally fine. People don't always click with each other. People sometimes give information in ways that you don't really fully understand what they're saying, or just something doesn't feel right. Get another opinion. That's okay. No problem. If it's my prostate and I've seen my MRI and the lesion's off to the side and I say, great, should we just zap that thing and avoid everything else? Unfortunately, no, not yet. We can't do that yet. Dr. Seibert's working on it. The imaging is getting better and better. It's not that good yet. The MRI is really good at identifying the worst part of the cancer. It's not perfect at identifying every single cancer cell in your prostate. So what happens if you treat just one focal spot of the prostate. Your PSA goes down, that part of the cancer goes away or dies, but then you get a prostate cancer that pops up on the other side of your prostate. So the majority of the time, we do whole gland treatment, whether that's taking the whole thing out with the prostatectomy, treating the whole gland with radiation. But then, because we know where the worst part is, we give it extra radiation because we know that that improves outcomes. So get the MRI, make sure you know where your tumor is, plan to give extra treatment to that area, but right now we still have to probably treat the whole prostate. There are selected circumstances where that might not be true. If I'm into my 80s by the time I get it, it's a fairly low grade thing. Sometimes then we think about a focal treatment as sort of a kick the can down the road approach. But the recurrence rates are higher than we like still, and I do think we'll get to a point where we might not have to treat the whole gland in everyone. But for right now, we're not quite there yet. Again, if it was me, I'd really want to make sure that we're getting a focal boost to the area if you can see it well on the MRI. The big questions you need to ask all the doctors is, how is this going to affect my urination, my sexual function, my bowel movements, and even my identity, which is sort of a weird thing to think about. But you know, these things, your testosterone levels, your sexual function, and things like that have been part of your life for however many years you've been alive on this planet. And when someone gives you hormone therapy and it takes away your testosterone, you're going to feel different. You are going to feel a little bit different. But you're not going to feel like a woman. You're not going to grow breasts necessarily. Your voice isn't going to change and things like that. So make sure you understand what it's going to be like. And being here is the most important part, because you really just have to talk to other guys. I can talk till I'm blue in the face about what hormone therapy is going to be like to you, but I don't know. I've never had it. You know what I mean? I've talked to a lot of guys, but hearing it from someone who's actually been on hormone therapy is much, much more important than having some doctor tell you what you're going to feel. And importantly, who can I talk to about some of these stressful feelings I'm having? This is a weird thing to happen to you. Right? We're going to talk about a treatment that affects a lot of very important aspects of your life. It's hard. Psychologically, this is a challenging time. Whether it's a new diagnosis, whether it's an ongoing diagnosis, whether you're cycling through different treatments, it's hard. Talk to the group. Come out here, talk to other members. Whatever you're going through now, someone in this group has gone through that before. That's for sure. But if that's not enough, talk to your healthcare team. Tell them that you're struggling emotionally with these things. Depression, anxiety is actually a very common aspect of prostate cancer treatment, and probably magnified by some of the treatments that we give. Okay. All right, go ahead.
Okay, this is from one of our members, Lance. Couldn't be here today, but he had this question he wanted to ask. So he said, hormones are used to shrink the prostate if the prostate is too large for brachytherapy treatment. This appears to usually take 90 days. So 90 days worth of hormone treatment. How long does the prostate stay reduced in size? That is, as the hormone treatment wears off, does this prostate start to return to its prior size, or does it stay permanently smaller? Assuming that the prostate starts enlarging again as the hormones leave your system, how fast or slow will that occur?
You know, that's a great question. Our perspective is usually that you do the hormone therapy to shrink the prostate, and then you do the radiation right afterwards. And then once you've had the radiation, had the hormone therapy, stop the hormone therapy, your testosterone comes back, the prostate does not regrow in size. But partially that's because the radiation makes it smaller on its own. So we haven't actually seen a lot of guys go on hormone therapy for a length of time and then stop it and to see how much it regrows. My sense is that it doesn't regrow all the way back to what it used to be, but it does regrow some amount. And that would be over months. Tyler, do you know? Have you seen any MRIs like that? Or? Yeah. Yeah, it just kind of stays small, right? Yeah. Yeah, so I think most likely it doesn't really grow back very much at all.
Do you have to have hormone therapy if you go into radiation?
It depends. Yeah, I know.
That's two questions with the group, huh?
Yeah, good idea. So that's essentially the end of my talk. Thank you so much for listening. Wanted to go through all these questions with you.
I'm sorry we're going long like this, so we understand if anyone wants to leave, we're not offended, please. So what I'd like to do is just put a few chairs up here, and then people can do general questions we'll do that for a few minutes, and then we'll just break. And then I'm going to ask my physicians to stay. And then if you go out, you can just walk up to them and ask your individual questions. But again, anyone who wants, needs to go or wants to go, please you just do that, okay? So why don't we start, if anyone in a group, yes.
Question, I haven't heard anything today about theranostics and use of pharma-carried radiation elements. Is that going to fall in your group, or is that going to be under medical oncology?
So you're talking about lutetium, and what exactly, which ones are you talking about?
Lutetium, Pluvicto.
Yeah, so there is so there are injectable radioactive sources that can go to bones and other things. That's often a nuclear medicine side. So it's a little different than radiation, even though some doctors who do radiation use that. And Brent, it comes up all the time, probably in some of your patients.
Yeah, it comes up a lot. It's a little bit more of a discussion for medical oncology and nuclear medicine. Actually, you know what, Dr. Seibert is our imaging expert. Do you want to just...
Yeah. Did you turn off the AV system?
We would consider that for patients with metastatic disease. That's the first easy answer. So if you don't have metastatic disease, it's not on the table. I've got patients who come in that they have need to treat, and they've asked for Pluvicto because they've heard the ads. That's completely the wrong time to use it. It's usually given in a nuclear medicine department or a radiation oncology department, radiation medicine department. But the discussion about whether to use it or not will probably be between you and your medical oncologist and your radiation oncologist. But if you don't have metastatic disease, you don't even need to worry about it. If you do, then that's who you talk to about it. And usually it's not the first thing you get, it's after you've progressed on other therapies today.
Wait, actually, can I circle back to the question that we had before? Can everyone hear us okay without the microphone for now? Okay, perfect. So the question was, do I need to use hormone therapy with radiation? And I answered depends, which is a frustrating answer, I know. But essentially, if you want to know what the standard guideline recommendation is, and we always kind of want to avoid giving specific medical advice to any person because we haven't seen all of the aspects of your case. Happy to see you in clinic and chat things more specifically about your case, but in general, if someone has what we call an unfavorable intermediate or high-risk prostate cancer, hormone therapy makes radiation work much better. And the reason is when we take away the testosterone, the prostate cancer cells sort of go dormant and sort of lose the capacity to repair the effects of the radiation. So when we hit it with the radiation, the cancer cells are much more likely to die and go away and never come back. So that is the kind of guideline recommendation for those things. Are there people who have intermediate or even high-risk prostate cancer that might not benefit as much or might be cured with just the radiation? Absolutely. The hard part here is that we don't know who those people are. So if you look at the trials where they do a randomized trial, 500 people get radiation alone, 500 people get radiation and 6 months of hormones, for example. The majority of those patients would be cured just with the radiation. When you add the hormone therapy, maybe 10 to 20% more are cured with the hormone therapy.
So Brent, just one tricky thing, with the projector went up, we lost our mic, but the mic is still recording for the posterity. So you speak into the mic even though it's not.
Okay.
It may be a little, but we're on the CD and things.
Got it. So we don't always know who the people are that need to have that hormone therapy. Who are the ones that really are going to benefit? And there's a lot of really cool stuff coming down the pipe, whether that's genetic testing or actually digital pathology, where they're using AI to try to predict who is going to really benefit from the hormone therapy. But as of right now, hormone therapy does make it more likely to cure most cancers that are unfavorable or high risk. But whether or not hormone therapy is right for you is a totally different question, and that goes into your preferences on things. How much is that side effect profile that you're going to get from that hormone therapy going to affect your quality of life? How much do you value that increased chance of cure compared to the cost of the side effects of those treatments? So that's a very individual discussion that you really have to have with your doctor and with your family.
Does hormone treatment affect your bone density? I broke my finger 2 years ago. For 1 year, it never grew back. I had to go in and have a plate and a new rod put in. Now it's healing, but it's not healing to the effect that I would like to see. Will the hormone therapy affect bone density or repairs to the bones or repairs to your body?
Yeah, so two slightly different issues. One, does hormone therapy affect your bone density? Yes. Yes, it definitely can. So often if you're going to go on hormone therapy, particularly longer term hormone therapy, they'll do like a DEXA scan to try to see how dense your bones are. And then they might give you medications to strengthen the bones and things along those lines. And they'll usually give you recommendations for calcium, vitamin D, and those types of things. Does hormone therapy affect healing? That's a harder question. I don't know that it's very well studied at all. I would think that that would not be necessarily a contraindication to using the hormone therapy for your prostate cancer. But again, I don't know that much about the specific fracture and things like that. But generally, we wouldn't consider that as one of the main reasons not to do hormone therapy.
What's the guide now about 6 months versus 2 years hormone therapy after radiation? I thought we were trending earlier, but then I'm recently seeing people saying, no, you got to stay on it for a long time.
Yeah, great questions. Actually, maybe I'll pass that to Dr. Seibert, who can discuss some of the new trials on where we are going with that and how we can kind of help better tailor that to each individual person and with the collecting new information that we're getting.
Yeah, so this is where all these questions that you ask us, when we give answers, it's not because of, it's usually, I hope, if your doctor is really doing a good job, it's not just based on what we've seen personally, it's based on science that we've done very carefully to get results, where patients have been enrolled in a trial, and then we randomize preferably between the two options, because otherwise, if you look at two groups and one does better, but they all chose, say, brachytherapy, right? They might have had a reason for choosing that. Right? And so the reason they chose it, actually a really great example is surgery. If you look back, say, 30 years ago, and you look at patients who got surgery versus radiation, the surgeons didn't want to operate on the patients who were older and sicker, right? And if they had more advanced cancer, they also weren't going to have a surgery because it wasn't going to cure them. But the patients who were younger and healthier and had less aggressive cancers were more likely to get surgery. So if you look at the two groups, who did better? The surgery group. Was it because surgery was better? No. And we know that because now we've done a randomized trial where we flip a coin because really nice, wonderful, altruistic patients said, I'm willing to let the flip of a coin decide which one I get. You're telling me you don't know which one's better. I will let you flip the coin, tell me which one I get. That way you'll learn what's the better option, and for the patients in the future, you'll know the answer. Now we know. It doesn't matter which one you do first, your chances of being cured are the same. We need those kinds of trials to answer these questions, and we have really great trials to answer those questions right now that you're asking. So should we do hormone therapy or not hormone therapy for patients who have intermediate risk prostate cancer? We have a trial that's asking that question. Should we try one of the new drugs instead of the old hormone therapy? We have a trial for that. The idea is that it might be just as good or better at curing patients, but with less side effects. So we don't know unless we do the trial. So we're doing the trial, but we need people who are willing to put themselves in the position of being a participant to benefit patients in the future. And for the question of short-term versus long-term, we also have a trial to ask that question. Now, we did those trials before. Decades ago, the trial of short versus long-term hormone therapy for patients with aggressive cancers, that was done. Long-term was better. But we didn't have genomic tests for tumors back then. So now the trial is you get a genomic test. If your genomic test is high, we ask, should we give you additional, more intense therapy? If yours is low, we ask, can we get away with a lot shorter therapy? And these are really exciting trials. I think they're going to work, but we won't know until we do them. And so, I encourage you and anybody who's diagnosed, think about it. And to participate in those kinds of trials, you need to go to a place that runs trials, which would be in our region, UC San Diego, and we can talk to you about those, whether it's a good idea, whether you're eligible, and if you feel like it's a good decision for you to participate, which we're so grateful for.
And then the standard, just to follow up with that specific question, the current standard is unfavorable intermediate is 6 months of hormone therapy. High risk is typically 18 months to 2 years. And if you have multiple different high risk features, and particularly high risk, they might add on a new medicine like Zytiga or something along those lines to be able to give it a little bit more punch. So that's the current standard, but that will change as the
So we'll go up in the back.
standard, but that will change as the
So we'll go up in the back.
Yeah, I hear a lot about the nuts and bolts of what you're doing, and I'm really curious to know if you, at UCSD, with your cancer treatments, if you include a prehabilitation plan for people in their treatment plan, meaning physical prehabilitation to reduce the possible burden of comorbidities, to get people in better physical shape, especially when they have been taking perhaps ADT and they're looking at getting SBRT. Because this can all be very hard on your body, and it's the older you get, the harder these treatments are. And it would seem that prehabilitation is something that needs to be included in the discussion.
You know, it's a great question. We don't have a formal prehabilitation program, and so that is something that would be really interesting to look into. Typically, when someone has a new cancer diagnosis, we do want to get started in the reasonable time frame. And the thing that's really going to affect your physical well-being the fastest, probably, is the hormone therapy. In particular, you're going to have weight gain around the belly, muscle mass loss. And if you're a little bit older, just losing a little bit of muscle might get to the point where it's a little hard to get out of the chair, and that can really affect your functional status. And so whenever we start someone on hormone therapy, we aggressively teach them, you're going to start watching your diet. You're going to have to start exercising. Whatever you do now, you're going to have to do more to try to minimize the effects that the hormone therapy is going to have on you, particularly.
I was thinking more just in terms of prehab is very useful before anyone undergoes any kind of surgery, is making sure that you are having muscle mass loss, that you're in the best physical shape you can be, because your recovery is faster. That's, I think, been demonstrated. So I'm wondering, maybe this is a study you need to do with having people in a formal prehab before they undergo any kind of surgery or any kind of exhaustive treatment like that.
I think it's a great idea. Yeah, so that's great. So there is the Live Strong program, which is a fantastic program with an excellent website, a lot of really good patient-facing materials. I'm not quite as, does anyone else have a little more specific? Vitaly?
They're not on Live Strong in particular. And you're right, we do need to do a study to really know how to optimize that, because we can give general recommendations, like, you can go to a website like Live Strong and use that program. You can go to a gym, you can go to a trainer, but what is it exactly you should be doing is, that's hard. Just like even those of us who don't have cancer, you go to your doctor and ask, what should I be doing for my diet? Those questions are difficult, right? Every day on the news, there's like, this is going to cause cancer, and then this is not going to cause cancer. It could be the same thing on a different day. That's because that science is tough. We're not lab rats. So what we do is complex. But some things have come out that are pretty strong themes, and I would say the Prostate Cancer Foundation has a lot of good resources. I have I'll leave business cards in a second here, and on them there's my lab website, which has there's a QR code to the for patient section that has a list of resources, including a webinar on diet, and also exercise. What I can say is most clear is you need to have resistance and strength training if you're on ADT, right? So if every patient I meet, if they're going to be going on ADT, I say starting now. It's great if you're doing cardio, and you should be, but you need to add some resistance training that is tailored to what you're at right now. You're not going to be full bodybuilding mode, but you should be doing something. That is also the best thing you can do. So it's best for your muscles, best for your weight gain, and for your bones. It also gives you more energy. It's the best way to fight the fatigue that I've seen. Yeah. I'm just going to say, sorry if I just mentioned, It's 12:17. I know we're over, and there's so much enthusiasm, which is excellent. But
Why don't we do 2 more group questions, and then we're going to, people come up to the individuals. We'll take that individual there, and we'll take you here in the front. So.
Yeah, I'm just, I have a question about treatment of lymph nodes, but I was directed at UCSD to a nutritionist called me up, and we talked about protein intake, protein shakes, you know. And then also the Livestrong program, I'm starting Monday at YMCA. It's a meeting with a personal trainer twice a week, doing the weight training. That's really good. I think my question is, I'm starting the proton therapy in a couple of weeks at the Proton Center. I had my imaging, and I had kind of imaging envy after hearing your talk. I don't know how the Proton Center's MRI and CT compare to like the stuff you were showing, but anyway, I'm.
Yeah, you'd have to talk to your doctor, I think, to see if it was adequate for you, right? The details of each patient and the circumstances, and like everybody wants what's the latest, most advanced imaging and everything, but sometimes it matters, sometimes it doesn't, right?
I'll be blunt. So the CT imaging at the Proton Center is the same. The scanner is, it might even be the same exact scanner that we're using over the university on the CT side. The MRI scanner over there is excellent. They're not doing the RSI imaging, that the color wash that Tyler is showing. There are other ways of looking for the dominant intraprostatic nodule on the other MRIs. It's not quite as slick as his method. We want to get to that point at the Proton Center with the RSI imaging, but we're not there yet.
Okay. They need, you know, I had it yesterday, and they need to get the headphones. They only gave me earplugs because they said the headphones were out of order, and I mean, I don't even know.
This is the person they're talking to.
But Mike, I don't want to take up too much time, but my question is this. So I have high-risk intermediate, PSMA shows no spread. I've got a high decipher and intraductal diffusion. So, you know, it's recommended to do the lymph nodes as well. But I was concerned about side effects and quality of life, you know, and all that good stuff. So I do have the option of just doing the prostate and not doing the lymph nodes at this time, but I think I talked to Dr. Davis, and it was like, if it was me, I would do the lymph nodes. So, you know, with protons. So, I mean, I just didn't know if you guys would weigh in on lymph nodes, no lymph nodes, can it be done later,
Well,
should it be done now?
Yeah, it's hard to weigh in on your exact case in the front of 100 people. But, you know, I don't know which specific physician you're seeing over there. I hope it's not me. But I would say, you know, knowing the folks who work over there, if they're recommending you treat your lymph nodes, I would trust them. It's well tolerated in general. Brent can probably address it more specifically. And it's easier to do it now than it is to try and patch it together on the back end. A lot of what radiation oncologists are thinking about is, okay, what's the backup plan here? And the backup plan sometimes for us is really, really tricky, because then we have to create a gap, and are we missing something, or is there going to be an overlap area? So I think the side effect profile is low enough that if somebody's recommending it to you on the front end, it's easier to do that than to have the oh shit moment on the back end.
There is a nice randomized trial asking that question. So in general, just treating the prostate versus treating the lymph nodes with photons, not protons, it increases the chance of moderate bother of the bladder by 10%. So if we treat 10 patients with the lymph nodes, 1 in 10 is going to have more side effects on average. 9 in 10 are going to be fine. So it's not a huge increase in side effects, and it's probably a little less with protons than it is with photons. Yeah.
With proton, talk about intermittent radiation therapy. And I'm wondering some of the disagreeable effects of radiation therapy. Do they wear off if you go off the radiation therapy? And how long does it take if they do wear off, or if they never wear off? And so that's my question.
What do you mean intermittent ADT?
Yeah, I think you're talking about intermittent hormone therapy. Yeah, so I think it's a good one to talk about, because when we talk about drugs,
the rules of the game can be very different than the rules of the game for radiation. Radiation, you want to get it started, get it done without breaks, without big 2 weeks in the middle, on and off, all these things, because it's more effective when we do it in a timely fashion. That doesn't mean if there's a holiday or something that the whole thing is ending. But in the 1980s, when I started training, we would give 2 weeks of treatment break in the middle of radiation to try to make the side effects less. The cure rates were less when that was happening. So radiation, big no-no, having intermittent. Hormone therapy, there's a rational thing, and that's kind of the art of the hormone therapy, because giving on and off hormones has a lot of positive things about getting off the side effects, but it has a really special aspect. The tumor resistance can be pushed off and kicked down the road if you're not always on it. If you just get on hormones and stay on it for 10 years, the tumor will become resistant faster. So the medical oncology doctor comes on and off with the hormones. We call it a holiday from, the drugs. So they're doing that not only to help you get your strength back and, your quality of life back, but it's to really delay the chance of becoming resistant, because I know several people in the room are resistant to the hormones. And that limits the card that the doctor can play. But if they do the intermittent, that doesn't mean you won't become resistant, but it does hopefully delay that, and it gives the ability to use hormones longer, because when you're resistant, then that's where chemotherapies and others become the frontline therapy. Okay, so why don't we break, and if a couple, I'm going to ask my physicians to stay for a moment.